Good afternoon and welcome to today's presentation, Whiplash Hyperflexion-Extension Injury. In today's webinar, Stephen will discuss the definition of whiplash, types of whiplash, range of motion, the effects whiplash has on the body, and reasons for non-healing. To give you a little background about our presenter, Stephen Simon is a medical director at the Pain Management Institute and also enjoys professional shifts at multiple establishments. He is assistant clinical professor in the Division of Physical Medicine and Rehabilitation at the University of Kansas Medical Center and Touro University. Stephen Simon is also a clinical associate professor in the Department of Family Practice at Kansas City College of Medicine and Biosciences. Attendees who require passcodes, the word for today is injury. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log onto your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list to the left of your screen. Thank you for all attending today, and Stephen, the presentation is now turned over to you.
Thank you very much. I appreciate that, and I appreciate those in attending to discuss a little bit about the problem that we call whiplash, also called a hyperflexion-extension injury to the neck itself. I want to give special thanks to Dr. Abrams and Dr. Thacker, who have participated in giving me information that's made this presentation possible. As we see, a couple of things occur in a rear end collision. Obviously, there's more than one way to get a whiplash, but the typical one we look at is a car which is stopped in the front, struck by another vehicle in the back, and the occupant has a body which is belted in place and restrained by a harness, but the head is not. So the initial force pushes the entire body forward because it's restrained to the chair or seat, but the head goes backwards. And so the initial force for the cervical spine is that of extension, and then there is a recoil by muscles that sense this hyperextension and go into flexion. Just an example that this doesn't just occur in motor vehicle accidents. Obviously, sports and other types of injuries can lead to a similar phenomenon. What's going on in whiplash? What is it? Well, over the years, there's been some changes in the name. So whether we called it a sprain, strain of ligaments, whether we called it an injury to the facet, which is a joint of the neck we'll talk about in the body of the slide deck, or whether we talk about it as a nervous system injury to muscles, nerves, ligaments, and so forth, all of this represents our understanding of what's going on in the cervical spine when it undergoes this type of trauma. Sprain strain actually is a term that is frequently used. In a study that was done in Europe and actually listed in the Journal of European Spine, didn't find any CPK level elevation, so they assumed at that time that sprain, which means that the muscle would be torn or damaged, was not occurring, that the strain was there, but not a sprain. If your muscle is injured, CPK is one of the chemicals that would leak out, essentially, and since it didn't go up, that's what that showed. To look at the facet itself, we're talking about a joint. This can also be called a zygoapophyseal joint, but it's harder to say that than facet. And what these joints do is they allow movement of the neck normally, but in a high force, they allow a spearing type action that can damage both that facet and the area around it, whether it's cartilage or whether it is ligament that's involved. This is a schematic, a picture of what the cervical facet looks like, and you can see on the right side of this screen that there is normally a gliding motion. This gliding motion at the facet joint does a couple of things. Number one, it allows movement, but number two, it allows a gradual change in the size of the neuroforamen or nerve hold. You can see that on the left side of the screen. If you notice that little blue dot in the middle of the bone, there's a circle of the red that says facet joints, and then there's a little blue circle toward the middle. That little blue circle really represents a place where the nerves exit, so that if that hole through the movement of the vertebrae above and below becomes squeezed, then you actually get some pressure on the nerve root, and that can add to the damage. In an impact like we saw in the initial slide of the two cars colliding, instead of a simple smooth motion, you get both a rapid vertical impact as well as a twisting. If you can imagine that you're pressing down on a jar, twisting it open, you're getting both of those pressures applied to the spine. And that can cause a variety of problems, not only to the joint, but also to the disc. And what happens is that this can cause a tearing and causing these facets to pinch or even lock in place at the time of injury. And one of the things that makes this type of injury perhaps more frequent in the neck is that while the rest of the spine has what is called a three-joint complex, there's two extra joints in the cervical spine, which means two extra places where this can be injured. And those fancy names are the uncovertebral joints of Luschka. But we'll show a picture of them in the next slide. But the interesting thing, if you'll notice the third dot, because here it really highlights what's going on in the cervical cord. Compared to the lumbar spine size of the vertebrae, the cervical vertebrae is much smaller, maybe a fourth the size, or a half the size. And yet it still has to house a spinal cord. It still has to give off nerves. It has blood vessels that come in here, and you don't have a lot of extra space. As a result of that, when you start compressing things, here you tend to have a lot more potential for problem and a lot more problem that develops. And here's a schematic drawing of the joints of Luschka. What you see overlying that perhaps may be more important, because just to the right of that line, you see what looks like a cylinder that represents the vertebral artery that's coming up through the spine. And just in front of the vertebral artery is the nerve root that is coming off of the spine at that location. As a result, when there is movement here, the movement is not just directed at bone, but can also have vascular and nerve implications in some people. Well, let's talk about what normal range of motion is. And what is shown here is normal cervical range of motion. The note at the bottom reminds us that because muscles are in play with the patient sitting up, gravity-dependent muscles, when I do an examination, I try to examine both sitting up and lying down, because then when the patient lies down, if there's a restriction, you will know pretty much where that restriction is coming from, as opposed to if the patient is sitting up where it could be a combination of both muscle and bone. It tends to, unless there is a muscle spasm at the time, it tends to be bone that prevents you from moving your neck if you are lying down and you've released the muscles. So we have three major movements of the neck. One is a side to side, so if you would turn your head to the left or right to look over your shoulder, that's a rotational movement. There's several different measurements. This one says 0 to 60, about 0 to 80 I think is more correct, but anyway, there is an accepted range of motion in that. The other is the lateral flexion. So now with your chin looking straight ahead, you're dropping your ear to your shoulder. That is a lateral flexion movement. You can go to the left and right, and about 45 degrees is the actual amount that you can move. And of course, the next is flexion extension. This is nodding your head yes and no. So I ask my patients to look straight up at the ceiling and to bring their chin down to look at their chest wall. There are measurement tools that we can use, but this is what we consider normal. And then if we find that patients don't have that, it represents an abnormality. If you are rotating your head and you're, again, looking to the side, that movement occurs pretty entirely at the top two vertebrae. These vertebrae, called the atlas and the axis, will rotate, the atlas rotating over the body of the axis. Now, if you'll notice, the atlas vertebrae has no body at all. It's the only vertebrae that doesn't. It's more of a ring. Those small holes on the side where the man's thumb is represent a place for the vertebral artery to pass. So that when you are turning your head, you are merely rotating that top ring, called the atlas, over the axis. And you'll notice the body of the axis actually sticks up through the hole where the body would have been in the atlas. So this combination of atlas, axis, and then the occiput, which is the skull itself, represent a very important area. And we'll talk about why more later, but there's a lot of nerve activity, there's a lot of muscle activity, and of course the brainstem is right there as well. This is a drawing of cervical extension, and this is looking up at the ceiling. You're both stretching your neck, but you're also stretching muscles. The muscle in blue that's shown is a very frequently involved muscle in cervical trauma, and it is called the sternocleidomastoid. It is responsible for turning your head to the opposite side. So the one on the right helps to turn your head to the left. The one on the left helps to turn your head on to the right side, which is an interesting one. And I'll show you some drawings later on that show you where pain in that muscle can wind up. Cervical rotation, 0 to 80 degrees. And you see here, there's the sternocleidomastoid drawn in red in the figure on the left, just to highlight it that it has two heads. But here you are, you're turning your head to the opposite side. He is turning to the right, so the muscle on the left is the one that is more active. That same thing is true as he's turning to the left. The one on the right is more active. Here's your lateral flexion that's going on. And here you're dropping your ear from side to side in a normal fashion. Now it's kind of interesting. In this drawing, you see that the shoulders are at the same level. What we often see in a person who's been in who's had a cervical injury is that one of the shoulders tends to be quite elevated in relation to the other due to the spasm of muscles that go between the shoulder blades and the cervical spine itself. So what is going on with all of these type of things, and how do we get injured? Well, there's forces, and these are things that you can't see, right? This is force. You go stand in a windstorm, and you can't see the wind, but you certainly can feel it. And so we've got forces that are coming at several different angles. The vector forces are flexion, flexion rotation, lateral flexion, extension, extension rotation, and vertical compression. So when we first began talking about range of motion, we talked about simple ranges. What you see here are combined ranges. So that means that we are both flexing our neck and turning it at the same time. And especially for the attorneys, you may have well taken care of patients who were injured. They say, I was looking out the window and boom, I got hit from behind, and then they have all this sequelae of injury on their left side. It's because of those type of movements. What is in this slide deck and what you see here is that with specific movements, just a flexion movement, you can have the following problems, such as an anterior subluxation or a facet dislocation and so forth. With movements of flexion rotation, you get more of a solitary facet dislocation or an atlanto-occipital dislocation. And again, because of its position by the brainstem, that's horrible for the patient. When we have a lateral flexion injury, we can see fractures of the occipital condyle, and this is where the skull now is sitting on the upper portion of the spine, or we can see some first cervical vertebrae, this atlas, if you would, this first cervical vertebrae sustained damage. And a very strong extension type maneuver can produce fractures. And the hangman fracture is specific to the second cervical vertebrae. And so these rapid extension movements can do that, as well as other type of problems that we see in the neck. And certainly fracture dislocations have occurred from these injuries when enough force is given, especially when the head strikes something in the car. We saw them a lot more before the shoulder restraints that we have today. A Jefferson fracture is a fracture of the ring at C1, and that's different than the hangman fracture, so that's what's there. And it's talking about compression. This is head over neck, which is why you would have that type of a fracture occurring. The other thing that's often overlooked. Yes.
Hi.
Yes.
We're going to stop here for questions, and then you can continue presentation.
Okay. Can I do a couple more slides first, and then I'll do it because I want to just finish this thought train?
We just have to. We just have to have.
Fine.
Okay. First,
let's take questions.
First, all the attendees can enter in the passcode for today. Okay, and our first question, when so many patients do well within full recovery after whiplash, why do some have more problems?
Well, the reality is there's a whole spread of reasons for that. Obviously, the force at impact plays a role, whether or not you have a healthy neck versus an unhealthy neck. One of the problems that we often see here in the clinic are patients who have a pre-existing arthritis or pre-existing surgery. In fact, I've had some conversations with patients who have had cervical surgery, and I've told them, you can't drive unless you're wearing a neck brace for the rest of your life, because should you be in an accident, this type of situation you have can set you up to be paralyzed. So those type of patients are exposed to a whole variety of reasons. Over 90%, or roughly 90%, of the patients who have these type of traumas do very well. They make full recoveries. It is for that reason that it's very frustrating when we have approximately 10% who don't. And not all of these problems show up on x-rays. In fact, one of the issues we have are, especially in emergency room, someone's been in a whiplash type injury, and the report from the x-ray comes back negative, normal. Well, that to an emergency room physician can actually mean that there's no fractures. That's what they're looking for. They're looking for acute trauma that might require a hospitalization or surgical intervention. But I've seen things listed as normal when the patient has totally lost what is a normal curve because of straightening and even some subluxations that were missed. I'm going to show some pictures, some x-ray photos of some subluxations, and they may appear normal, and then we'll show why they're not.
Our next question is, why are some whiplash injuries more painful than others?
Remember that we're dealing with a series of ligaments, tendon, nerve, bone, all in a very tight space. So that if this particular injury, and I showed earlier that nerve hole, if that nerve hole gets compressed and a nerve gets squeezed, that nerve is now traumatized. It's going to swell as we see the acute inflammatory process, and therefore you may have a pain that goes all the way down your arm. One of the problems that we get in these injuries, 10% that don't heal, is something called an anterior scalene syndrome, where you have muscles called the scalenes that come out of the front side of your neck, and your brachial plexus runs through those. And so if that muscle goes into spasm, it squeezes the nerves that go down your arm, and in fact it would look like you had a radiculopathy or a pinch at the nerve root of the 6th cervical vertebrae, but yet You take an X-ray, you do an EMG, and they all come back normal. Well, if you do an evaluation of the neck in terms of its range of motion and you feel for spasm directly, what you can find is that this pinch or impingement of the brachial plexus has occurred, and as a result, you have patients with an entrapment problem. And those are one of the main aggravations of these patients, that someone has failed to diagnose it, especially those professions that tend to look at X-rays and say, oh, well, the X-ray's fine, you're fine. We tend to see that. I'm not taking aim at orthopedics, but orthopedics is more of a black and white type of a practice where they're going to look for fractures or they're going to look for loss of bone height or something to indicate that there's been a problem structurally, as opposed to how I was trained as a physical medicine doctor to spend more time looking at that complex of nerve and soft tissue and evaluating for that. There's actually books that are written that address these entrapment phenomena.
Next question is, why does the insurance company always claim there was not enough force to cause this injury?
That's because insurance companies like to find reasons not to pay claims, I think. But you want, in all fairness, you want to understand how an injury occurs, and you say, how could a small force do this? There is a correlation to a degree with force causing injury, but it's also real estate, location, location, location. I'm one of 4 children, 3 of whom are boys, and we used to hit each other in the arm. Maybe you did that to a brother. And as long as we hit each other on the side of the arm, which is, in those muscles, you're not hurting yourself. But if you'd have done that same force to the shin, you'd have done a lot of damage. So location is important. Was the head turned at the time? What was the condition of the neck? Those are the things that really present the problem. And this is one of the ways that the insurance company tries to understand how the accident occurred, or how the injury occurred more directly. What was the force? What was the position of the head? Did it strike anything? And so forth. And they try to make sweeping claims. Again, I've already said that 90% of these tend to resolve without further issue. But it's the 10% that we worry about and what's going to happen with those. And I think that's really the issue. Those who really care about the 10% versus those who want to lump everybody into the 90% and say that 90% represents the whole, which it really doesn't.
Okay, this is our last question for this section. Could an accident that causes whiplash also cause a muscle injury like a hernia?
Hernia in the neck is not a common type of a problem because there's not really the tissue to be stretched out for it. Hernias, we tend to see more groin, abdomen in that area. If the seat belt, and this is one, we experience these more when the seat belt took the force without the shoulder harness, because the seat belt itself put a tremendous amount of force through the abdominal area. And I've seen everything from hernia to actual perforation of bowel that has occurred from a seat belt in and of itself. So technically the answer is yes, and it just depends on where the force is. I just never seen any hernia in the neck, chest area. This is more abdominal groin type of a situation.
Thank you so much for answering those questions. You can just continue with the presentation.
Great. All right, so we were talking about head and neck, and one of the things that we see a lot are headaches. I didn't have headaches before this accident. Now all of a sudden I have headaches. An overlooked part of the body is the jaw joint. The reason we can talk, the reason we can chew is because of this. This joint happens to sit very near the trigeminal facial nerve that comes through, and this is why it becomes so tender. What I'm showing now is the examination of the jaw itself. So what we do is we look at the ability of the jaw to open. We have a 3-finger rule. It is normal that you can put your mouth, open it wide enough so that 3 of the examiner's fingers can fit inside your mouth. The jaw happens to go side to side, and we want to balance that left side versus right side. It also goes forward and backwards. So we want you to jut that jaw forward and bring that jaw back to make sure that's all balanced. And finally, we have you open your mouth and place our fingers at the joint itself, which allows, if you do that, just put your hands not in your ears, but just in front of your ears, and start talking or just opening and closing your mouth. And what you'll feel is the movement of the joint. If we feel that that joint is not balanced, it's sticking out more one side than the other and so forth, that can make a huge difference. And of course, obviously, if it hurts when we do that, that tells us we're on to something. That can frequently cause not only facial pain, but also migraine headaches. It's a trigger for about 10% of the migraine headaches that I see in the clinic. So sources of cervical pain, and this slide maybe answered one of the questions that was asked. You can have trauma, you can have infection, you can have a referred pain, you can have all sorts of muscle pain, and you can have disease of the cervical disc as well as degenerative changes to the joints. So all of those things exist, and of course it's our duty as a physician to try and diagnose where it's coming from. This next group of slides is really illustrative, and I know it sounds bizarre, but I actually had the opportunity in a court case of a whiplash to show a series of slides and do a mini demonstration for a jury about what you're about to see and why it was applicable to the patient, over the objection of the other attorney, I might add. So this is a normal extension of the spine as your head is going to move backwards. You notice that all of the vertebrae are moving at the same time in sequence, so you have a nice steady move. But if it is a hyperextension, in other words, a very rapid non-stopped extension, what you're seeing here is that you can actually have a variety of injuries, which include injuries to the vasculature, injury to the nerve, injury to the ligaments, and even bony fracture, the spinous process on the backside underneath his head, which can be injured in this very rapid type of a movement when it's not controlled by the neck itself. So here we are. This is called a cervical acceleration-deacceleration syndrome, which is another way of saying whiplash. Let's watch what happens here in an accident. Because the head weighs more than the spine, and because the trunk is usually held in a seat belt harness, you have the head moving at a different speed than the spine. So now, after the head goes backwards, it is now coming forwards, and it is moving at a different rate of speed. Therefore, the translation of that through the bones of the spine cause you see it in white underneath the white head on the right side. It says superior articular facet of C5 and or C6 spears the articular facet at 4 or 5. So what's happening is this. If the movement is coming at the facet and the facet is moving erratically, you end up with the facet damaging a nearby facet. And that's what is occurring at the time of this. A hyperflexion injury can cause these type of injuries itself, including injuries to the nerve, injuries to the disc itself, or fractures or compression fracture to the vertebrae if the muscles can no longer stop that from happening. Ligament damage doesn't show up on X-ray, but ligaments are what hold our bones together. So it's very important to understand that if there is excess movement, it's because the ligament has been damaged. And this is what we try to show on radiographs. What you're seeing here is an abnormal flexion and a normal. So the spine on top, and these are actual films of the spine, showing a normal flexion with no translation. So flexion obviously is chin down. Translation is going to be a side-to-side or forward-to-backward movement. Now, the bottom one shows significant movement. And just go ahead and take a second and look at the dotted line that you see in the top picture, and then look down below where those circles are, and you can see the sliding of the one they're labeled, vertebrae 3 to vertebrae 4 to vertebrae 5. There is not equal space between them, And if we highlight them, you can actually see that that line is broken now where the ligaments have been damaged to allow this movement. You would not see that in a regular X-ray. You have to order flexion extension films to see that, and that's the importance of getting a whole series. If you just get a regular X-ray, normal, and that's what it would look like. But when you start forcing movement by flexion extension, then you see these. And of course, what you're seeing here in a schematic is those type of injuries that we used to see before the harnesses were there, where the head actually came in contact. And what's important here, if you'll notice the area where the brain is, you do see some small microbleeds, which may or may not show up on a CT scan. You can damage the eye, and of course, you can cause these type of movement in the spine that can lead to a spinal cord injury, fractures, and esophageal tightening. Muscle injury is more common. This would be the sprain, as it were, to the muscle. Where the muscle is damaged, you have the scalenes, and there's some pictures. I had already spoken about them in terms of what we call a scalene syndrome. And the splenius capitis, it's a very external muscle, which is why it tends to be injured so much. The front one says the sternocleidomastoid, and that is a particularly important muscle. We've shown it a couple times, but it's very significant, and you'll see why when I show you where it refers pain. But this is what happens, not only the bones, but also the muscle. This shows you the various areas where the facet joints can actually cause injury when they are coming with a force, especially when there's vertical forces. If you look at 2 and 3 on the right lower side of the screen, you see areas there which cause some changes in the way one vertebrae sits on top of the other. You notice that there is an opening, again, these little blue holes in the middle of those bones, which are places where the nerves normally exit the spine to go down across the chest wall into the arm. And so those are what's seen in that mechanical injury itself. Hyperextension, we've addressed, and so I won't address it again. But this is an important sequence here. One of the problems is, I mentioned the brain stem involved, especially in the upper part of the spine. If you look here on the left side of this screen, what you're seeing specifically, these yellow areas represent the nerves that are coming out. These are spinal. These are the spinal nerves, if you would. Pinch those, and you get a radiculopathy or a nerve root irritation. The red areas coming up toward the skull is the vertebrae, and these, is this vertebral artery, and you have 2 of those. That's very important because they bring blood to the brain stem. So the normal alignment is that you're going to have vertebrae 1, vertebrae 2, and occiput. And this is what we had addressed before. You are now seeing them. Those holes, the big hole in the middle, the foramen magnum, obviously is to allow the brainstem. The smaller holes on the side allow the vertebrae to come up into the brain. So one of the things that's been noted, and it's been highlighted, that axial rotation of the atlas can cause symptoms of vertigo, nausea, tinnitus, and visual disturbance. This is all brainstem. This means that the brainstem has been trapped in the movement, and you're about to see, if you'll watch these slides, what actually occurs with injury. So you're seeing here that the vertebrae is rotated because of muscle imbalance. So one muscle is pulling further. In this case, it would be pulling to the right so that the vertebrae rotates, but the net result is that you now have a smaller space through which the brainstem operates, and the brainstem is getting pinched. That's another, that doesn't show up on x-rays either very well, and the only test that really shows it up well is to get a CT examination with 3D overlay so that you see if a pinch is occurring at the brain stem. Anterior subluxation will occur when these posterior ligament complexes are no longer viable, and a rupture or a tear occurs. So therefore, you can have this movement to the front because the ligament in the back is no longer holding. And so if you skip down a couple below the yellow highlights, it says mechanism, anterior subluxation caused by a combination of flexion distraction. So the flexion movement and a lifting up in the back at the same time at a rapid rate of speed can do that. Clinically significance because this type of injury is associated with a 20 to 50% incidence of ligament of failure, and now you have an unstable vertebrae which goes on and on and on for the patient. You've stretched it, and it's going to make more problems. What you're about to see is what the x-rays look like in that sequence. And just to highlight it, the black line is the line of the cervical spine. What do we see? There's supposed to be a soft curve toward the chin. You don't see that curve, right? This is almost a straight line. If anything, it may even go backwards. So the cervical curve has been lost here. The other thing that you're seeing is that the relationship of vertebrae 1 to vertebrae 2, and highlighting it in the yellow markings, show that there's a bigger space there. So this is what you would see on x-ray if you take the time to look for it, and it's this what's called a subtle anterior subluxation. Now you're going to see something that's a little more major that even we can see when we look at it. Hopefully we take the time to look at it. Bilateral facet location, extreme form, and this is going to, when this subluxation occurs now, you're stretching one vertebrae over another. But what is a vertebrae housing? What is it protecting? The spinal cord. So therefore, the spinal canal becomes compromised, and this can cause a stenosis, not only affecting the cord, but the neuroforaminal outflow. And an MRI will show this pretty well, and that's a type of test that would reflect that. Here is some of these facet injuries on x-ray, and like I said, if you look on the far right side, this shows greater than a 50% dislocation. We can see where the bone is and where the bone isn't. We can also see this 25 to 50%, and then on the front side, this more mild 25%. But these are all indicative of changes of the facet due to loss of ligament stability. You are not going to see these looking straight on. These are a side view, if you would, of the x-ray. Now, we've talked about nerves, and nerves can be damaged as well. They can be pinched, or they can be damaged beyond that. They can be irritated, and the very bottom is what our patients are going to feel. Tingling, cooling, burning, numbing, electrical type feeling. These are all typical complaints that people have, and if we have pinched the nerve either through muscle or either through its positioning going through the nerve hole, that can happen. Ligament is more commonly injured, and this can be stretched from the injury. Once broken, the duct tape that holds it all together is no longer there, and of course this can lead to a perpetual problem, which is one of the reasons why patients continue to have injuries. Discs, on the other hand, don't get injured as much unless there is a significant force, with the exception, asterisk, 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 of patients who had pre-existing degenerative disc disease. One of the problems that we've seen in terms of patients who don't heal are those people who had a pre-existing degenerative disc in the neck. It was kind of an accident waiting to happen, and now the accident happens where you've put force through a system that can no longer act to accept the force and pass it on, and then it leads to disc tears or disc ruptures, small herniations or larger herniations. And that's the thing. Discs change shape due to pressure. Think of it like a plastic jelly bag. And if you squeeze it at the top, it's going to squirt out the sides, right? So this is common, except that when you tear the sides, now you squeeze that jelly outside, and that's exactly what's happening. Here is instability again shown. This is a non-fracture instability, and it's highlighted. Again, look at the cervical vertebrae. On the bottom two, you don't see much change if you look at it, but yet if we take an oblique or a side view, and you start looking, you see that these vertebrae look entirely different. and we've lost our C-curve, and we've also lost any type of normal stair-step fashion that the vertebrae take. So this is a type of thing we would see on X-ray. If you looked at a patient like that, that patient would look normal to you. That patient doesn't have an obvious, oh, gee, your neck is out. That's why you have to do those. So this is called the syndrome of the cervical facet. And what happens here, you don't have a motor or sensory deficit, but what you do see is a kind of this ill-defined pain, and that's due to the fact that you don't have good nerve innervation going to the facet, but you do have some innervation there. And it's when this is a joint, and so you can have a lot of aching in that joint, just like your knee or your shoulder and so forth. There is a referral pattern, and they're shown here that basically if you damage this occiput C1, C2 complex, you get a lot of behind the ear and occipital pain. The reason for that is that your greater occipital nerve that supplies sensation to your head comes up through that area. And now you've created a situation hostile to that nerve's passage. So therefore, it's a trigger for migraines. It can cause occipital neuritis. And the lesser occipital nerve supplies that area up over the ear. Imagine you held a banana over your ear. That's kind of the distribution of that nerve pathway. So that's what you see. C2-3 is forehead to eyes. C3-4, the suboccipital region, the back of the neck. And below that, it's pretty much neck and shoulders, and supraspinatus, infraspinatus are talking about the shoulder blade area. So these are typical referral patterns that we see that we try to focus on. The only reason I'm showing this slide here is that where the needle is going, you notice there's multiple layers of muscle that go down about 6 centimeters to the bone from the outside. And these multiple layer of muscles, any one of them can get involved. But where the needle is a muscle specifically called the semispinalis. And that muscle is what is injected typically for migraines, for our migraine sufferer, because the nerve, this greater occipital nerve, is coming through that muscle or next to that muscle. Therefore, we want to relax that muscle. So any of these can get involved, but I wanted to show this slide just to highlight the depth of what's there. This is a person lying on his back. His head has been removed so that you are looking down on the vertebrae. The middle of that, this little heart-shaped, the red area are the muscles. If you see a little heart inside, that is the spinal cord. And if you look at this opening, this is this airway opening. This is obviously our breathing tube or trachea that you see there. At the very top of this screen, but just to try to orient what was there. These are common referral patterns, and this is why soft tissue is so important. Travell and Simons, no relation to me, the name's spelled differently, but Travell and Simons did a series of examinations on patients over the years and have published a lot of books that really highlight and have proven that these patterns are correct. Remember that sternocleidomastoid I talked about? That's the front X. The back area is the anterior, you have a posterior and anterior trapezius muscle, and then the area where the top X is where the insertion is for this sternocleidomastoid. But look at where the pain distribution is, not only in the neck, but also over the temporal side of the pain and even up over the forehead when that muscle gets stretched and irritated. Here is, the X's represent where we inject, by the way, but this shows that you can get from the superficial and deep head of this muscle pain in the back of the head, on the top of the head, in the face, or even in the eye. And this is very typical of what we see with a lot of our patients who have this type of injury to the sternocleidomastoid muscle specifically. This is a trapezius referral pattern up along the back of the head, and you notice it comes down even inside of the shoulder blade. This is a sub-occipitalis. These are very small muscles at the base of the neck, but they can't protect themselves in a rapid movement, either from compression or stretch, and so you get this pain that runs along the lateral side of the face above the ear. Obviously, we want to inject that to try to relax it. But overall, what we've talked about today are problems related to an injury that's affected nerve muscle, perhaps disc, facets, ligaments, and ultimately the person who has to house all of those. It's going to affect sleep, it's going to affect comfort, and it's going to affect ability to, do things in a, quote, normal fashion. And these patients have a lot of problems. The majority of the patients, as we said, will heal uneventfully, regardless just about of what they do. Most of physical therapy is aimed at stretching the neck and relaxing the muscle and being sure that it's balanced. Most of the medicines we use, anti-inflammatory and muscle relaxants, tend to help treat those aspects. For those who don't heal, we have to do specific testing to find out where the problem is. And the simple sprains and strains are really not simple at all, because as a result of these forces, we can lose stability of the spine, we can lose balance of muscle left to right, and we can develop a whole series of neural compression syndromes that remain a significant cause of the problems that our patients tend to live with. And so I want to thank everybody for joining us today. Obviously, we're going to have a lot of questions. As you see, this is several ways of saying we are at the end of the presentation itself.
If all the attendees can enter the passcode, our first question for today is, I'm wondering about the science behind traction. Is it effective in treating cervical spine injuries such as bulging discs?
There's two types of traction. The traction that happens in a physical therapy office is helpful. There's two ways to provide it. One is static, where you just pull and hold it at that tension, or the non-static or oscillating, where you pull it and then you relax it, and then you pull it and then you relax it. The purpose of this type of traction is to bring a muscle which is shortened, because when a muscle gets irritated, it will shorten to protect itself, to bring that muscle back to its normal resting position. Another type of traction that is done is what the chiropractor does with the attempt to repair discs. That's a whole different phenomenon. But I was trained that traction is valuable in the acute phase. Whether or not it's helpful after 6 weeks really depends on whether there is ligamentous instability. One of the things that a chiropractor would do, if the chiropractor were providing therapy for you, would be to traction the neck and then try to reposition vertebrae A over vertebrae B. And a traction is part of that. So the answer to the question is yes, but the qualification is it tends to be more appropriate during the first 6 weeks of healing. For those patients who are unstable, and then you have ligamentous damage, traction may be beneficial beyond that when the head no longer can assume its normal position. Therefore, the traction allows the body to put things in normal posture again. Unfortunately, you turn your head and so forth because it doesn't have the stability, you'll fall back out and you'll need that traction on an ongoing basis.
Next question is, are the forces exerted on the spine the same for a car which backs into a pole or other immovable object and a stopped car which is rear-ended? I'm sorry.
Okay. I think if I've misunderstood the question, please say it again. But it sounds like we're talking about forces. And if a car is struck from behind, one of the questions I ask if I'm doing an IME, for instance, I will say to the patient, was there a second strike? And that's important for a couple of reasons. If you're in a line of cars and you're struck from behind, but you're pushed into the car in front of you, depending on, obviously, how hard that happens, it had to be hard enough for you to hit the car in front. Your body is exposed to a rapid force coming from one direction, and then very quickly a rapid force coming from another direction. What's happening in your neck is we have sensors that can pick up tension in the muscle, so that if you flex your neck, your body knows that. If you hyperflex your neck, where it's a sudden movement, you have now pulled your stretch receptor, and the body kicks into emergency gear to put your head right. In other words, you get hit from the back, your head is now moving in that direction. It's going behind you as your body is going forward. You are overstretching the receptors in the muscles that would stabilize your neck from the front side. This is often the sternocleidomastoid, by the way, which is why we keep talking about it, and the scalenes. And now you will have something called a recoil. So the recoil is going to whip your head back to a normal alignment position. Unfortunately now what's happened is that now you are hitting another object. So now you have a force coming the opposite direction, and it's doing the same thing in reverse, and so therefore you are coming and going at the same time with those forces, and it creates the potential for a lot more injury specifically for that, because the body never has a chance to correct itself and is attempting to correct itself with a awkward hyper movement in the opposite direction. Just like you do if you've ever tried to skate on ice and you start to fall, you start flailing. And that's kind of what's happening to the muscles in your neck when there's a second strike. So whether that second strike is to the car ahead of you, whether that second strike is to a tree or a curb, you have hit something that's changed the forces going through your body and aimed at your body. And a lot of that depends on how well you're protected. Most people don't drive like NASCAR drivers with a helmet on that would protect your neck. And so the head can move around in response to any of those. If it's from the rear, it's a forward-backward movement. But what if it's from the side? And this is what happens in the second strike. You're pushed forward, and now your left front wheel hits a curb or hits a tree with the left front of your car, and you've got that force coming at an angle, so your head is rotated, and now you've got these different factors. So you really start having combined injuries that change the lay of the land quite a bit. And it is very important to understand mechanistically what happened to the patient in an effort to try and resolve it. We haven't mentioned some of the cervical dystonias that occur where the muscle goes into a chronic spasm and really pulls the head in a direction. These are very, very tough to treat, but that's another aspect.
Next question is, how much force is needed to cause these types of injuries? Example, the speed of the car or amount of force needed.
Yeah, there's a lot of written work that talks about that, and I've had attorneys ask me, well, the damage to the bumper was just a mild dent, or there was no discernible damage. How could that do all of this? Again, I haven't found over the years, and I've been doing this for about 30 years now, that while there is a correlation, obviously, with heavier forces doing more damage, what I've found is what the neck does. We've all been scared. I like to play peekaboo with my grandkids, and so my 7-year-old grandboy will jump out and you say, "Did I scare you?" And what happens in a situation like this, especially was the neck turned to the side. I would agree in general principle that if it's a small amount of force and there's little damage to the car, that there shouldn't be a whole lot of injury. And yet I've seen things happen that don't relate to it. And the reason, the qualifier, is that what was the state of the spine before that injury occurred? So you may have a spine that may have had other injuries. You may have a spine that's very degenerated, that has a lot of bony spicules around nerves, against ligaments and so forth. And so those, even at a very mild force, especially if the person is jarred, is going to have a lot more potential for injury than someone else. And we've seen, just like we've seen cases at a pretty high rate of speed where the frame is bent on the car, the neck's fine. We've seen other cases with relatively mild injury. And so in general, yes, higher force, more injury, but not 100%. You've always got those few percent that, for a variety of reasons, will get injured. Most of it is pre-existing disease or how the head was positioned in front. Obviously, we're ruling out those who would be after secondary or tertiary gain in a situation like that, but actual injuries. And I've seen plenty of these patients after the case is settled who say, you know what, I really hurt, doc, can you do something to help? And those are the cases that tell you that, okay, case is over, but your patient still has pain. What do you do? And that's what we do in pain clinics is try to help these folks.
Next question. Would the headrest prevent these type of injuries?
Headrests are marvelous at preventing a great number of injuries, but the headrest has to be positioned correctly. If you're a tall person and the headrest is low, it actually acts like a fulcrum for you, and you go right over the headrest. So you have to position the headrest for your head size. And if it's not done so, it can be a weapon instead of something that could be an assist. Yes, a headrest will stop a lot of these, especially the initial hit where you go backwards, and so therefore you don't have the recoil forwards on that type of injury. But the headrest is only going to work for the initial strike from the back. If you get struck from the side, of course your head is moving side to side. If you get struck from the front, then your head is going to move in that direction. So you've got, the answer to your question is a qualified yes, as long as it's a simple rear end collision. If it's the head if it's positioned correctly, it should stop a lot of those injuries.
Next question. Would tensing your muscles in anticipation of an impact help reduce injuries to make them worse?
Yes and no. I've seen it both ways. You know, we've seen plenty of drunks that have been in some fairly severe collisions, and they don't seem to have much happen to them in terms of pathology. You know, for some reason, maybe they're very, very relaxed or whatever. Tensing is something people do, and I don't have a good feel for that makes it better. I think what would be better to say is if you can prevent the head from moving. If you see that there's going to be an accident, you know, put your hand over your forehead and push back into the headrest to keep your head from moving. That would be the best thing you can do. Tensing up may do that if it's a small enough force, but unfortunately, it may lead to further problems if the force is high enough. It's not going to help you.
Next question. Is there a time period in which to order flexion extension films for you to correlate the films to the accident? Will the spine correct itself, and if so, within what period of time?
Magic number in medicine is 6 weeks. We tend to think that most things are going to heal within a 6-week time period. Yes, the body is going to attempt to heal itself. If the ligament has been stretched mildly, it probably is going to heal itself just fine. Where you run into problems is ligament tears or muscle attachment tears that may not show up on an X-ray. So when the patient, obviously if you are trying to relate this to an event, the sooner after the event is the best for it. But you know, it still needs to be done if the patient's continuing to have symptoms. And so one of the things that is done in your area, you might want to talk to one of the pain clinics, or if you have physicians who have use of a C-arm, because now what you're getting in a C-arm is a real-time fluoroscopic image of that head going into flexion and extension, and you can visually see during this period a movement of bone, as opposed to what I showed you in these films, which were X-rays showing some slippage of one bone over another. There you can actually see it pop out, and from a jury perspective, I think it's pretty convincing to see that movement. Otherwise, just looking at it on an X-ray, especially if the patient is standing still, you might not see it. So as soon as possible, and those real-time fluoroscopic cervical extension flexions are the best, in my view. The flexion extension done still with a neck fully flexed and fully extended are the second best, and that's what I showed you X-rays of today in this particular report.
Next question is, most doctors refer whiplash patients to physical therapists for treatment. Can you address whether this is effective or not?
Well, it's certainly how I was trained. Remember that what we have is an irritation of muscle primarily, not that nerve can't happen and ligament and so forth. So what you've got is you have lost range of motion, and you have irritated muscle, which probably is going to have shortening or spasm. As a direct result of that, what physical therapy is going to do in the modality side, they're going to put on hot packs or they're going to do an ice massage. Those who are trained can actually do mobilizations or directed energy where I put my hand against your head and I say push against my hand. I'm now stressing the muscles that would make that movement, and yet the neck is not moving at all because I'm trying to exhaust that muscle so it'll relax and then I can get more movement of the head. So, you know, what's happened today is quite a bit different than when I began practice 30 years ago. When I began practice, there was a lot of hands-on activity. What I see for physical therapy today is, here's a sheet of exercises, go do them. And unfortunately, what you need is more like I was trained with, where the physical therapist does a hands-on. So to say physical therapy is not enough. What you need is a physical therapist who understands muscle and nerve and who will work for this to resolve this type of an issue. Yes, it is absolutely imperative that the patient gets to somebody who will do that. Some chiropractors do that, but physical therapists should be doing that, and they will use hot, cold, ultrasound. Some of them use soft, what are called red lasers, which is a cold laser, if you would, to try to relax the muscle specifically. The whole goal is how do we return this neck to a normal position and get this head over neck appropriate and get its range of motion back. So heat, traction are what we usually go for first to try and just relax those muscles, get them back stretched out, start to get some range of motion, and then ultimately end up strengthening those muscles so that they're back to the position they were before the injury.
Okay, thank you. And next question is, can herniations occur in the absence of degenerative disc disease?
Can you repeat that? You mean can a herniation occur? Of course. If there's enough force, a disc is a two-part syndrome. Imagine a lifesaver, if you would. The center of that lifesaver is filled with a jelly. The outside of that lifesaver is more like a callus. And so you have this two-part disc that's in your neck. And whether it's in your lumbar spine or whether it's in your cervical spine, there's a difference in size, but the mechanisms are virtually the same. The purpose of that disc is it's a jelly bag and it's surrounded by a more firm tissue. But enough force on that, you're going to get a tear or a rip or a rend in the disc itself. The outer layer no longer can contain the gel because of the force, and some of that gel leaks out. Now, what happens is that gel is an irritant, so you're going to have a very local irritation. If it goes to the side, you're going to irritate the nerve root on that side, left or right. If it goes backward toward the spine, you can irritate the spine itself, and then you'll have that type of irritation. The symptoms would be associated with that.
And our last question is, can herniations heal themselves as well as disc bulges?
No. The short answer is no. That a herniation requires that you damage the outside of the disc. Once damaged, it's damaged. I'm not familiar with those healing. There was some intradiscal heating that went on. It's no longer FDA approved, where needles were placed into the disc. They likened it to dropping an egg into a frying pan and watching it harden. And that's what they tried to do, is to take that jelly, heat it up, and it would actually become more collagen-like, like a coating inside of a joint. It wouldn't be loose, as viscous as it was. Basically what you have is a jelly, and then it would be firm when it was done. But that was a different process. Nature doesn't do that. What will happen over time, once you have destroyed the outer portion of the membrane, is that pressure, normal force that you do is going to cause a little leak, a little leak, a little leak, and eventually you're going to run out of fluid to leak, and you've lost disc height. For those of us who age, we shrink, and part of the reason we shrink is that the softer disc material becomes harder and there's less distance between the two vertebrae around it, so that we can lose height. I've seen several inches lost in some patients just because of that. So this system is built on hydration. This system is built on the ability of the body to transmit force. And once you disrupt that system, it unfortunately does not heal itself. It will continue to dissipate over time.
Okay, thank you so much. And we do have a lot of more questions. Is it okay if we can give your contact information out to the attorneys for them to discuss the questions they had for you, the remaining questions?
Certainly.
Or we can just send it to you, Doctor.
I have no problem with that, whatever works best.
Okay, thank you so much. We'll send that over. Also, in addition to being your best source for testifying and consulting experts for the past 60 years, TASA also offers e-discovery forensic solutions, free interactive webinars, cybersecurity services, day-in-the-life videos. Research reports on expert witnesses also include challenge history report 2.0, preliminary screening report, and expert profile 360. I want to take this opportunity to thank everyone for attending, and most especially Stephen Simon for his time and effort in presenting this presentation. If you would like to speak with Stephen, or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. This concludes our program for today. Thank you for attending.